Today we will discuss the drugs used in Parkinson's disease. But before we really talk about the drugs, we must know what is the pathophysiology of the disease, and we must know that what is the normal function of basal ganglia. Because first, if we know the normal function of the basal ganglia and normal circuits within the basal ganglia, then we will discuss that in Parkinson's disease, how the basal ganglia circuits and neurotransmissions are disturbed, and how those disturbed neurotransmissions produce clinical features of Parkinson's disease. And then later on we will discuss how different drugs, at least symptomatically, reverse the neurotransmission dysfunction in the basal ganglia. Right? So let's start with the very basic about the basal ganglia. Right. So let's suppose this is your central nervous system. Right? In the midbrain, here the very important structure which is called substantia nigra. This is substantia nigra. Then when we talk about the basal ganglia, we can show them in this diagram that this is outer part which is called striatum. Right? There's a caudate nucleus here. Under it, what is this here? Putamen. And putamen along with what is this? Putamen with caudate plus putamen together are called corpus striatum. Again, I've put the striations here. That is, this is caudate nucleus. Here is putamen, and caudate plus putamen together are called corpus striatum. In our discussion, right, we will calling these two structures together as only striatum. Is that right? Now onwards in the lecture, caudate and putamen together will be called only striatum. Then this structure, right, this is called globus pallidus. What is this structure called? Globus pallidus. It has one outer part, external part, and one internal part. Right? External part of globus pallidus is called globus pallidus externa. And this is called globus pallidus interna. And more medially, if you come, you will find that here is thalamus. What is it? Thalamus. And just under the thalamus, there is a nucleus. And of course, because it is under the thalamus, this nucleus should be called subthalamus. These all structures are called as a group basal ganglia. So next time when someone talk about what is basal ganglia are the structures which are very deeply present in the both cerebral hemispheres. These are masses of the gray matter, right? And they are very intimately related with the motor functions of the central nervous system, right? Now, let me draw a section of the brain like this from the front. Is that right? And we see how the basal ganglia are placed. Suppose this is cerebral hemisphere on one side, and this is cerebral hemisphere, of course, on other side. Here is your, what is this? Midbrain, pons, medulla, and of course this downgoing is spinal cord. Right? Now in this view, I will place the basal ganglia exactly how they are present. Before I really place them, you must know that at the top of the midbrain, there are two big masses of gray matter here. Can you tell me what are these gray matter masses? Yeah? Thalami. These are thalami, right? Basal ganglia, I'm going to draw it here, and this structure is outer structure. Let's suppose this is representing corpus striatum, but actually this is putamen, and along with the caudate, it makes the corpus striatum. And this is globus pallidus. So corpus striatum, globus pallidus, here it is thalamus, here again thalamus, again on the other side also we have the same structures, globus pallidus, and there is corpus striatum. Which part of the corpus striatum is this one? Please? Putamen, very good. And if I put another part of the corpus striatum here, what is that one? Caudate, right? Caudate. Then, what is the structure here? Yes, please. Substantia. Yes, please. Substantia nigra. And what is another structure present over here? Yes. Subthalamus. Is there any problem up to this? There's no. Now, just memorizing these structures like this is useless. We have to see how do they function. We are becoming doctors. We must know how these structures function, and when these structures are damaged or there is problem, what type of dysfunction occur, how that dysfunction lead to clinical presentation, and how the drugs work into this area. So let's start with, first of all, how this system really works. Now we will go to the circuits of this system. Let me remove these things, and this is included, suppose here, functionally quadrate, and put them in the same, so I'm just showing this. Now, when you plan a movement, when you think of a movement, which part of the central nervous system is concerned with movement thought? Anyone? No. First of all, let's suppose I plan to show you this marker, where the thought initiated, and which was the area in the central nervous system which really thought to initiate the movement. That was the premotor area and prefrontal area, right? Again, let me show on the side view that from where the thought for the movement started. I'll make it a very simple. This is your premotor area, prefrontal cortex, which is concerned with your personality and thought. This is premotor area, prefrontal cortex, right? Premotor area, supplementary motor area, and primary motor area. You must draw it. It's worth it. This is prefrontal cortex, which is concerned with what? Your thought and personality. After that, there is premotor area. Then there is supplementary motor area. Then there is primary motor area. Is that right? Now, all of you know that from primary motor area, neurons come down as corticospinal system. And this corticospinal system influences the lower motor neurons, and these lower motor neurons lead to the activity in the muscles. Is that right? This is very simple. Everyone knows the corticospinal pathway coming down, and it controls the lower motor neuron outflow, which eventually lead to the effector activity in the muscles. But actually, when we plan to make a movement, then from here, I will make a very simple, first of all, from prefrontal cortex, and from premotor area, and from, what is this? Supplementary motor area, the connections go for the movement. Listen, when I decided to do a movement, actually these areas in the central nervous system show electrical activity, and they are connected with the basal ganglia. Now I'm showing in this diagram basal ganglia as a very, very simple way. This is basal ganglia, right? Here is your midbrain. Basal ganglia as a group. Is that right? Why connections come to the basal ganglia? Because, motor programs for the basal ganglia are present. Motor programs for the movement are basically present in the basal ganglia circuit. Let me tell you, when a small child, newborn child, do you think newborn child can write? Can type? Right? But you can write. Why? Because you have done a lot of training. And when you do a lot of training with writing, neuronal circuits develop. Those neuronal programs which are made with practice, they are actually, those programs are present in basal ganglia and cerebellum. Right now we'll talk only about basal ganglia. Is that right? You have learned so many things. Maybe you have learned how to play basketball. Now all the movement, do you think during the game you are really thinking, now I should contract this muscle, now I should relax this muscle? No, automatically basal ganglia are providing the body with the motor programs. Is that right? So a lot of motor programs are stored in basal ganglia. So when you are going to do a movement, the movement initiating centers should come to the basal ganglia to activate the motor programs. Is that right? Listen, if I want to wave my hand, it's a different motor program, right? And if I want to show you double thumbs, it's a different motor program. Is that right? Now these programs are stored wherein? Basal ganglia. So thought process should come to the basal ganglia, right? Now from here, basal ganglia have reciprocal special connections with substantia nigra. They also have special connections which I will discuss into detail with subthalamus. And then basal ganglia, once they finalize the motor program, that which motor program they should activate, they give the program to thalamus. Via the thalamus, this program will fire back to supplementary area and premotor area. From here, final refinement are done and information goes to, what is this? Primary motor cortex. Then primary motor cortex will start firing and stimulating the lower motor neurons, which will fire in such a pattern and move the muscles in such a pattern that desired movement is produced. Am I clear? No problem in this? Now, meanwhile, this is called pyramidal system, right? There is extrapyramidal system also. Extrapyramidal system consists of olivospinal pathway, consists of rubrospinal pathway, consists of reticulospinal pathway, and many other pathways. Actually, this output from thalamus also influences extrapyramidal system also. So what is really happening? That when you thought of a movement, right, you thought really in your frontal cortex, right? Then the demand for the motor program will be made to the basal ganglia. Basal ganglia will consult with substantia nigra, of course, which is part of the basal ganglia, and also with the subthalamus. Then final motor program will be fed to the thalamus. Thalamus will go upward, loop back, right, and then pyramidal system will be activated. Plus from thalamus, fibers will come down to extrapyramidal system, and extrapyramidal system will also fire. Now, what is the difference in function of pyramidal and extrapyramidal? Pyramidal is concerned with fine voluntary movement. Pyramidal system is concerned with fine voluntary movement. Extrapyramidal system is concerned with tone, posture, and initiation of the movement. Let me write here. It is concerned with initiation of movement, of purposeful voluntary movement, Secondly, it is concerned with tone, and it is concerned with posture. This is the function of extrapyramidal system. Is that clear? No problem in difficulty up to this? Just by an example. Let's suppose you want to kick a football. So voluntary movement is to kick the football. To kick the football, you have to initiate a movement, and it's a purposeful movement. To initiate the movement, extrapyramidal will help, and basal ganglia will help, and because it is purposeful movement, pathway will be coming from whole this system through corticospinal. But when you are going to kick, the tone in the body will remain same, or it will be altered? It will be altered, because when you are taking 1 foot off the ground, then tone in the other side of the other lower limb will be altered. Girdle tone in the hips and the back will be altered. That adjustment, background adjustment, will be done by the extrapyramidal. Is that right? Even right now, you try to write something, please. When you try to write something, voluntary movement of the finger is done by pyramidal. Try it. But you will see with that, there is some tone change around the change in the shoulder when you are trying to write. This is purposefully occurring, voluntarily occurring. This is automatically occurring. This is done by pyramidal system, and this background adjustment is done by extrapyramidal. Am I clear? So basal ganglia are the headquarter of extrapyramidal system, plus they do influence the pyramidal outflow also. Is that clear? After this basic discussion, let me show you the circuits of the basal ganglia. I will just draw the basal ganglia of one side, and we'll see what are the neurotransmissions going on. substantia nigra. And here is your, what is this? Thalamus. And here is your which nucleus? Subthalamus. Is that right? No problem up to this? Now, to stimulate the movement, from cortex fibers are coming. Is that right? These corticostriatal fibers. These striatal fibers. These are stimulatory fibers. These are stimulatory fibers, and some fibers are releasing acetylcholine. So they are called cholinergic fibers. And other fibers release here glutamic acid. So they are called glutaminergic fibers. So we can say as a step 1 that they are corticostriatal fibers, and corticostriatal fibers are mainly stimulatory fibers, and they consist of which fibers? Cholinergic fibers and glutaminergic fibers. Is that right? Now we look at the internal circuit of basal ganglia. Basal ganglia are very important inhibitory neurons. Is that right? What are those neurons? This is an inhibitory neuron, and this neuron goes from striatum to globus pallidus, which part? External. This blue neuron releases Gaba, gamma aminobutyric acid. Now let me tell you how the Gaba work. This is a neuron which will release Gaba, right? Now Gaba will act on the next neuron. And what is the function of Gaba? Who will tell me? Let's suppose this is the Gaba which is released by this. Gaba will act on the next neuron. What is the function of the Gaba on the receptors? It inhibits the next neuron. How it inhibits? How the Gaba inhibits? There are 2 ways how Gaba inhibits. Listen, I'll make this even larger. There are 2 ways how the Gaba can work. You know, this neuron is now very sad. Why? Because it is going to be inhibited by GABAergic action. This Gaba will come and it will bind with this receptor, and this receptor of the Gaba is actually coupled with a chloride channel. It is coupled with chloride channel. It means whenever Gaba bind with this protein, it automatically open which channel? Chloride channel. Now chloride is present more outside the neuron. Chloride is very rich extracellularly. So as soon as chloride channel open, lot of chloride go in. Now tell me one thing. Whenever Gaba work on a receptor, some of the receptors of Gaba are coupled with which channel? Chloride channels. Chloride channels open up. Heavy amount of chloride will go in. A lot of chloride goes in. Cell will become more negative or less negative? More negative. If resting membrane potential here in this cell, resting membrane potential was minus 90. When a lot of chloride come, this resting membrane potential will become more negative. If cell become very negative due to loading of chloride, do you think it's easy to stimulate this cell? No. Because stimulation means that if this is resting membrane potential, stimulation means that you should bring resting membrane potential to threshold and then action potential start. But when you are loading the cell with chloride, it becomes too much electronegative. So because after Gaba action, resting membrane potential has become more negative, now it becomes more difficult to take the resting membrane potential to threshold. So cell become inhibited. Actually, this is a basic rule that whenever a neuron become more electronegative, it means normally neurons are negatively polarized. Resting membrane potential is negative polarity. When it becomes more negative, it becomes more polarized, it becomes hyperpolarized. So anything which make a neuron hyperpolarized and more electronegative, it becomes difficult for a neuron to be stimulated. GABA make the neurons electronegative by 2 ways. One way is load the chloride in the neurons. It has another way also. The GABA B receptors. Chloride channels, GABA A receptors. The GABA B receptors and GABA B receptors, when they are stimulated, if GABA bind with GABA B receptors, they are intracellularly stimulating the G inhibitory protein. and when G inhibitory protein is stimulated, right, one of the function is it opens the potassium channels. Which channels? Potassium channels. Now potassiums are more inside the cell or outside the cell? Yes? Write down, cells are the bags of potassium. Every cell is rich in potassium. So whenever, in any cell, whenever you open the potassium channel, because potassium more inside the cell, it will jump out. So what really happens, that when GABA act on GABA B receptors, they are coupled with G inhibitory protein, which eventually through multiple steps lead to opening of potassium channels, and potassium jumps out. And when potassium will come out, cell is losing the positive charges. So cell will become more electronegative. So it means GABA knows how to make a cell inhibited. It has two mechanisms to inhibit a cell. Either GABA will work through GABA A receptors or it will work through GABA B receptor. If it works through GABA A receptor, it opens the chloride channels. And chloride is more outside, so it will jump in. And when cell gets more anions, it becomes more electronegative, more hyperpolarized, more difficult to stimulate. Number two, GABA may work through GABA B receptors. And GABA B receptors are coupled with G inhibitory protein, which eventually lead to opening of potassium channels and let the cations come out. If potassium come out or cell loses the positive charges, again it becomes more electronegative. So it's clear to everyone that GABA makes the neurons electrically inhibited. Am I clear? Now, actually, GABAergic fibers are here, and these GABAergic fibers, this pathway which I'm drawing, these GABAergic fibers from striatum to external globus pallidus, they release what substance here? GABA. Then there is another GABAergic fiber here, neuron. And this neuron, right, this neuron will release the GABA in where? Where it is releasing? It is releasing in the thalamus. Just let me make it a larger diagram so that it becomes less messy. It's a very important diagram. It's out of proportion, but it's worth it. Right? Now what we will see, that these were your stimulatory neurotransmitters. This is releasing acetylcholine and this is releasing, yes please, glutamic acid. Right? And both of them are inhibitory or excitatory? Why you did not ask me that how they excite the neuron? You are not bothered? Or there's some other reason? This is GABAergic system. Do you want to know how they excite? It's very simple. Acetylcholine has receptors which are with sodium channels. And glutamic acid has a receptor which is with calcium channels. Acetylcholine, I will make this neuron here. This is acetylcholine coming out, and here what is coming out? Glutamic acid. Is that right? This acetylcholine has channels which are coupled with what? Sodium system. Right? As whenever acetylcholine bind here, this channel open, and this channel is sodium channel. And when glutamic acid come and bind with its receptor, this is the receptor for glutamic acid, it is coupled with calcium channel. Listen, sodium is more outside the cell, calcium is also more outside the cell. These are the basics you must know. Extracellular fluid has more sodium and more calcium. So whenever sodium channel will open, sodium will jump in. And whenever calcium channels will open, calcium will jump in. So it means both of them bring cations in, positive charges in. Of course, any activity which bring in the neuron more positive charges, that will take the resting membrane potential towards threshold. So neuron will become inhibited or stimulated? Stimulated. Is that right? So corticostriatal pathways are stimulatory, and these pathways are cholinergic pathways and glutaminergic pathway. Cholinergic pathway load the neurons with sodium. Glutaminergic pathways load the neurons with calcium. Both of them take the resting membrane potential towards threshold, and this will fire. But this neuron itself is inhibitory. It means these two pathways are stimulating the inhibitory neuron. Inhibitory neuron will release what? GABA. And when GABA will be released, the next neuron in the pathway, which is this one, when GABA will be released on this neuron, this will become loaded with chloride, or it will become deloaded with potassium. In both cases, it will become inhibited, right? But anyway, this neuron is going where? To thalamus, right? Now, in the thalamus, if I draw the diagram of thalamus, this is the side of thalamus. On the side of the thalamus, there are three nuclei: ventroanterior, ventrolateral, ventroposterior. Actually, these GABAergic fibers, they are coming to ventroanterior nucleus and ventrolateral nucleus. From here, now this is stimulatory pathway going back to where? Yes, where it is going back to? Cortex. This was the loop. Stimulatory pathway coming to basal ganglia. Basal ganglia have heavy inhibitory pathways, and then eventually stimulatory pathways go back. Am I clear? Now this pathway is called direct pathway. This is called direct pathway. Why it is called direct neurotransmission pathway? Because it starts directly from striatum, going directly to the globus pallidus internus and directly to the thalamus. Then there is another indirect pathway as well. How that works? This is also GABAergic neuron, right? This is also GABAergic neuron, but this neuron goes to, what is it? Globus pallidus? External, not internal, external. From here, GABAergic fibers come to, what is this, your friend? What is this? Subthalamus. They come to subthalamus. From subthalamus, okay, I will draw it even more clearly. This is subthalamus, right? Now look. From subthalamus, these are GABAergic neuron. Excitatory fibers go back to, what is this? What is this? Globus pallidus internum. It means, and of course, there are stimulatory pathways coming to this as well. Is that right? Now, look at it. This pathway is direct pathway to thalamus. This pathway is going first to the subthalamus and then going back to the system. So this pathway is called indirect pathway. Am I clear? Now, in direct pathway, there are two GABAergic fibers, neurons. And indirect pathway, there are initial two GABAergic and then subthalamus to the globus pallidus is excitatory. This is glutaminergic. This red pathway is glutaminergic. Is that right? Now, all this talk, and there is no mention of Parkinson's disease. I think we should talk about that also. Isn't it? Let me tell you. Fit into where our Parkinson's disease is coming. That is related with substantia nigra. From the substantia nigra, okay, I will make it also more simple. This is substantia nigra. From the substantia nigra, there is a very big group of neurons which fire to striatum. These are neurons which are connected to striatum, and they are connected with the direct pathway as well as indirect pathway. These are called nigrostriatal pathway because they are going from substantia nigra to striatum. So these are called nigrostriatal pathway. So these nigrostriatal pathways, right? These nigrostriatal pathways, they are concerned with direct pathway as well as they are concerned with the indirect pathway. Is that right? Now, these nigrostriatal pathways are dopaminergic pathway. What they release? They release dopamine. So this terminal has dopamine, this terminal has also dopamine. Is that right? Now, when they will release the dopamine, of course, postsynaptic membrane should have dopamine receptors. Here there are dopamine 1 receptor and here there are dopamine 2 receptors. Is that right? Now I will tell you what is the whole system. Dopamine 1 receptors and dopamine 2 receptors for direct and indirect pathway. This was going your direct pathway. And this was your thalamus, neurons going back. this neuron, and this neuron. Clear? This was your indirect pathway. And from subthalamus, clear? This is your, what is the subthalamus? And here is your substantia nigra. Here is your subthalamus. From substantia nigra, especially it has special area called pars compacta. From there, dopaminergic neurons go up, and these neurons are connected with direct pathway as well as indirect pathway. Here they have dopaminergic receptors which are called D1 receptors. Here they have dopamine receptors which are called D2 receptors. Is that right? Now. And here, of course, what were these pathways coming? Glutaminergic and cholinergic and glutaminergic, right? Of course, there's no fun in telling that we can draw the structure like this. Is that right? Everything put into perspective, this diagram is there, right? Now listen. What really happens, substantia nigra helps in initiation of the movement. How? They will release dopamine here and here. When dopamine 1 receptor is stimulated, it is coupled with G stimulatory inside. And when dopamine 2 receptor is stimulated, it is coupled with G inhibitory. Is that right? Dopamine 1 receptor is stimulating inside the neuron, G stimulatory, and dopamine 2 is stimulating G inhibitory. G stimulatory will stimulate this neuron. Is that right? So it means nigrostriatal pathway releasing dopamine on direct pathway stimulate the neuron, and when this neuron is stimulated, it will release a lot of Gaba on next neuron, and next neuron will get inhibited. When this neuron gets inhibited, can this inhibited neuron can keep this inhibited? No, because this is itself inhibited, so it does not release Gaba. When it does not release Gaba, so it is no more inhibited, and it will start fire and release the motor program. Let me show you again. Listen, we come to that diagram to here. Nigrostriatal pathway, fire. It releases dopamine on, first we'll talk about direct pathway. When it releases dopamine on direct pathway, the GABAergic neurons on which dopamine is released, they are having here dopamine 1 receptor. Rather, you should tell me. Nigrostriatal pathway is releasing which substance here? Dopamine. Dopamine is acting on direct pathway through which receptors? Dopamine 1. D1 receptors are coupled with G stimulatory or inhibitory? So, this GABAergic neuron is stimulated or inhibited? It is stimulated. When it is stimulated, it will release from this point which neurotransmitter? Gaba. When Gaba will come to this neuron, in globus, pallidus and ternus, this will load put a lot of chloride in, and this neuron become hyperpolarized. Now it is stimulated or inhibited? When it is inhibited, will it produce action potential? No. When it is not producing action potential, will it release Gaba in thalamus? No. When there is no Gaba release in thalamus, do you think these thalamic neurons are inhibited now? No. So they will automatically fire to the motor system, and then your beautiful motor system will eventually fire down and muscles will contract. Purposeful movement will start. This pathway is clear? Am I clear to you? Now, let's talk about the function on the indirect pathway. When this will release nigrostriatal pathway, will release which substance on indirect neurons? Again, dopamine, because it releases dopamine here as well as dopamine here. But on indirect neuron, it will stimulate D1 receptors or D2 receptors. When D2 receptors are, what is happening? Inhibited, because this is G inhibitory. When D2 receptor are coupled with G inhibitory protein, this neuron gets inhibited. When this neuron gets inhibited, will it release Gaba? No. Attention. Look at this neuron carefully. This neuron is GABAergic neuron. What is this? When it has action potential from its terminal, it releases GABA. Now come back. Nigrostriatal pathway is releasing which neurotransmitter here? Yes, please. What it is releasing here? Dopamine. Dopamine is stimulating which receptor? D2. D2 receptors in this neuron are coupled with G stimulatory or inhibitory? They are coupled with G inhibitory. G inhibitory eventually opens the potassium channel. The potassium goes out of this neuron. So this neuron becomes stimulated or inhibited? It becomes inhibited. When this neuron is inhibited, will it have action potentials? No. When there are no action potential, will this neuron release GABA? No. Then if it will not release GABA, so next neuron will not be inhibited at all. So it will become stimulated. Are you understanding? Action potential will start into this because no more GABA keeping it inhibited. When it will be stimulated, it will release a lot of what? GABA here. And this GABA will actually inhibit this neuron. This excitatory neuron get inhibited, and when it is not firing, will it release any excitatory substance there? No. Is that right? So what will happen? Will it be excited? Not at all. When it will not be excited, will it release GABA? No. So it means the gain deficiency of GABA where in thalamus. And thalamic nuclei are no more inhibited and they will fire. Right? Let's rapidly sum up it. Actually, to initiate the movement, first you should understand, let's start with a new perspective from this point. To really start a movement, stimulatory signals should go from thalamus to the cortex. Do you agree? To have these stimulatory signal going up, we should not have GABA here. Because if GABA is coming all the time, unfortunately basal ganglia are all the time releasing GABA here. So keeping many movements inhibited, it is good for us. Otherwise you will start automatic movement all the time. Is that right? All the time this pleiothalamic pathway is releasing GABA. Is that right? Now when you want to start a movement, actually this system should fire and bring the movement out. Clear? For firing of the system, you want this GABAergic system to work or you don't want it to work? We don't want it to work. This should be inhibited. Now, how this pathway can be inhibited? Right? That in anything which inhibit this neuron, GABAergic neuron, that will allow it to bring the movement out. Am I clear? Now I have to explain that how nigrostriatal pathway lead to inhibition of this. Inhibition can occur through direct pathway or through indirect pathway. Is that right? We will revise it and you will guide me. First of all, substantia nigra has an area called pars compacta. It has neurons which are projecting from substantia nigra to striatum. This pathway is called nigrostriatal pathway. What's the name of this pathway? Nigrostriatal pathway. This pathway releases which neurotransmitter? Dopamine. So nigrostriatal pathway is dopaminergic pathway. This thing clear? Now, it releases dopamine on direct pathway as well as on indirect pathway. On direct pathway, when it releases dopamine on the direct pathway, which receptors are present? D1. And these D1 receptors are coupled with what? G stimulatory. And G stimulatory stimulate this first GABAergic neuron. First GABAergic neuron, when it is stimulated, it produces a lot of GABA on what? Second GABAergic neuron. And second GABAergic neurons become inhibited. When second GABAergic neuron is inhibited, will it fire or it will not fire? It will not fire. When it will not fire, it will not inhibit the thalamic pathway. And thalamocortical system will start working. First thalamocortical system will work, then corticospinal pathway will work, and movements, lower motor neurons will work. Is it clear? Secondly, nigrostriatal pathway is also connected to the indirect pathway. On the indirect pathway, it releases which substance? Dopamine. Dopamine acts here on D1 receptors or D2 receptors? D2 receptors. D2 receptors are coupled inside with G stimulatory or G inhibitory? They are coupled with G inhibitory. So this neuron will get stimulated or inhibited? If this neuron is inhibited, then will it release GABA on the next neuron? So when this first neuron does not release GABA on the second neuron, it means second neuron is no more inhibited, so it will become active. But when second neuron become active, it releases on this subthalamic area what substance? GABA. When it releases a lot of GABA, then thalamic neurons are inhibited. When subthalamic neurons are inhibited. When subthalamic neurons are inhibited, can these stimulatory pathway, which is itself inhibited, can it stimulate this? No. Is that right? So when it is not stimulated, it means it is not able to release GABA. So this GABAergic deficiency develop here and these neurons fire. Am I clear? Now you may be thinking why Dr. Najib is so fussy about these transmissions. Let me tell you, there are diseases and drugs related here. Yes, you have a question.
The whole purpose of initiating the movement is that the prefrontal cortex and the premotor area is firing to the what you call it? I forgot what you call it. The little one.
This little one?
Yes, the information has to get to the thalamus.
Yeah.
And now we inherit everything from the thalamus. How the thalamus knows that we want to initiate a movement then?
Look, there are how the thalamus knows. Because thalamus is very heavy. Thalamus is also having motor programs, right? But actually, thalamus has a lot of gray matter in ventro-anterior and ventro-lateral nuclei. There are millions of neurons here and millions of neurons here, right? And there are very heavy connections between globus pallidus and thalamus. This is called pallidothalamic tract. This is a very important tract. This tract is determining the firing pattern of thalamocortical system. Is that right? Now, when you have to initiate different movement, there is different synchronization from pallidothalamic tracts. Is that right? Because there is not just one neuron. In my diagram, there is one neuron. But actually, there are neurons for the face movement, there are neurons for the leg movement, there are neurons for millions of the neurons connecting here, and there are millions of the neurons firing up. You know how many neurons you have in your brain? More than 10 billions. You're a billionaire as far as neurons are concerned. More than 10 billion neurons talking to each other. And you know, on average, one neuron makes how many connections with other neurons? On average, 10,000 connections. You just imagine, world population become 10 billion. And then, every person is simultaneously capable of communicating with 10,000 people. How many social network will be there? This is how your brain is right now working. Poor Dr. Najib is showing only one neuron here. You just imagine the function of your brain as world population become not 6 million, it becomes 10 million. And then every person has ear and tongue. Every person has 10,000 tongues and 10,000 ears which can work differently. How many social circles in the world will be there? That is how your brain works. Is that right? Now come back. There are many problems related with this area, right? For example, we say that when this Nigrostriatal pathway fails, a disease occurs which is called Parkinson's disease. What is Parkinson's disease? In Parkinson's disease, usually after the age of 50, in some people, unfortunately, these neurons start degenerating. Which neurons are degenerating? Nigrostriatal dopaminergic neurons. Parkinson's disease is a disease in which with age, right, the dopaminergic neuron from the pars compacta of substantia nigra start degenerating. When these neurons degenerate, again I'm showing here only one neuron, but there are millions and millions of the neurons. As these neurons start degenerating, then dopaminergic activity in basal ganglia is increased or decreased? Decreased. Now look at it. There is cholinergic activity in basal ganglia, this is excitatory, and there's dopaminergic activity which is mainly D2 inhibitory. So it means in a normal person, basal ganglia, there's cholinergic activity coming as well as dopaminergic activity coming. I will show you it as a balance. And in the basal ganglia, there's a balance of dopaminergic activity with, okay, I should make it with different color, this balance. This is the balance of neurotransmitter business in basal ganglia. One side there is dopaminergic activity, other side there is cholinergic activity. Cholinergic activity is corticostriatal pathway and intrastriatal connections, cholinergic. And dopaminergic activity is nigrostriatal pathway. These should be in balance to have a normal posture, to have a normal tone, and to have normal capability to initiate the purposeful movement. These two activities should be in balance. What really happens in Parkinson's disease that these neurons start degenerating. When these neurons start degenerating, dopaminergic activity is increased or decreased? Decreased. So when dopaminergic activity becomes less, it becomes very less. Dopaminergic activity is less, then naturally cholinergic activity is uncompensated. Cholinergic excitatory activity is uncompensated. Because it is uncompensated, so actually patient will have symptoms due to two things. Number one, due to decreased dopaminergic activity, and due to uncompensated increase cholinergic activity. Even though primary defect is not in the cholinergic pathway. Primary defect was in dopaminergic pathway. When dopaminergic activity went down, some problems will occur due to reduced dopamine activity. Right? And once dopamine is less, of course, uncompensated excess of cholinergic activity will produce some further problems. Now let me tell you what happens. Let's imagine, just imagine, these neurons are not working. Do you think, can you stimulate this neuron? You cannot stimulate this neuron. If this neuron is not stimulated, it means can this neuron release dopamine here? No. When first indirect pathway, listen, when dopamine is, nigrostriatal pathway is degenerating, there is reduced dopaminergic activity on direct pathway. The first GABAergic neuron is not having enough dopamine, and not having dopamine, D1 receptors are not stimulated. This neuron is not stimulated. This first neuron in direct pathway is unable to release what? GABA. When there is no GABA coming here, it will automatically overstimulate it. When it will overstimulate, it will release too much GABA here. When it will release excessive GABA here, this will be excessively inhibited. Can patient initiate a movement? So what really happens to this patient? That he plans a movement in his thought. But it takes a lot of willpower, a lot of determination to initiate the movement. So patient, for very small movement, you cannot really imagine, you are healthy people, that for him even to scratch a little bit is extremely difficult. If Carlos, unfortunately, just imagine, if Mr. Carlos gets Parkinson's disease, unfortunately, after 50 years, and dopaminergic neurons are not there. Is that right? And one day, Carlos has become a big neurosurgeon in USA, but unfortunately, he has developed Parkinson's disease. And one day, Irene wants to visit him, and Carlos wants to smile just, and he cannot smile. He will just keep on looking like this to Irene, to his girlfriend. He cannot smile. This little movement to make a smile becomes almost impossible, and it will take a lot of willpower. And that becomes very disturbing to these patients. They find it difficult to initiate purposeful movement. They are not easy, comfortable, reflex movements. Why? Because no dopamine coming here. Again, now listen, what is happening to Carlos? He is looking at Irene. He wants to smile, but what is happening? That D1 receptors are not stimulating this. When this is not stimulated, then first neuron is not releasing enough GABA on second. So second is not kept inhibited. Second overfires and release too much GABA here. That excitatory pathway is inhibited, and he cannot bring out the movement or facial expression. Then second problem. GABAergic neuron is also, dopaminergic neurons also work on which pathway? Indirect. On indirect pathway, when there is no dopamine, this neuron was inhibited by dopamine because it has D2 receptors. Now problem with the Carlos is that dopamine is not available here. This neuron is not inhibited. This neuron overfires. When it overfires, it inhibits this one. When this is inhibited, it cannot keep this inhibited. So it overfires and stimulates this one and further inhibition in this pathway. So with all his willpower, he has a difficulty in initiation of the movement. Is that right? This difficulty in initiation of the movement is due to reduced dopaminergic activity, and this difficulty is called hypokinesia. Or if it becomes very severe, we say patient has akinesia. Hypokinesia or akinesia. What problem is here? Hypokinesia or akinesia. This is one feature of Parkinson's disease. Second problem, there is excessive cholinergic activity. There is excessive cholinergic activity. Now, excessive cholinergic activity overstimulates the pathways which are concerned with the tone. So pathways which are concerned with the tone, they are overstimulated. They are not opposed by the dopaminergic. So what will happen? That those pathways, here I have shown only the pathways which are concerned with the initiation of movement, but the other pathways which are concerned with the tone and posture. And those pathways are overstimulated because they are no more inhibited by the dopamine. So all over the body, tone will go down or up? Tone will become high. So he will develop rigidity. Because tone in flexor and extensor both goes up. And muscles become more semi-contracted. So resistance to the passive movement will be more. So we say that he has developed rigidity. Are you understanding me? Right? So he will develop rigidity also here. Right? Rigidity. With that, another thing. What really happens, how we maintain the tone. Now listen carefully. Tone is maintained, for example, how we maintain the posture, okay? If I want to keep a beautiful posture like this, for some reason I want to maintain. If I'm a healthy man, I can maintain like this. How I maintain this? That my hand is in this position because tone in extensor and flexor is equal. And without tremor, I'm holding it. Is that right? Now, if basal ganglia are not working well, then what happens? Sometimes this overwork. When this overwork, then for correction that overwork. And these things start repetitively. And when this thing repetitively starts, that one movement overfires and then compensatory movement overfires and then compensatory movement overfire, what you end up with? Tremors. That is also due to increased cholinergic activity. Now why I'm so much again fussy that this is due to cholinergic activity? Because when someone has strong rigidity and has tremors, the drugs should be anti-cholinergic. And someone has the real problem of hypokinesia, drugs should be dopaminergic. We should give drugs which should enhance dopaminergic activity there. Is that right? So what is wrong with these patients? These patients have hypokinesia with tremors, right? And rigidity. And of course, if your body is rigid, do you think you will have a normal posture? No. So these patients have postural abnormalities also. If you look at well-developed Parkinson's patient, he will be standing like this. What is happening? Expressionless face. Right? He cannot afford to show the fine shades of expression, happiness, sadness, and all those. Right? Even blinking is reduced. It looks like this. What is this called? This is called serpentine look. Serpentine look. Like a snake. Snakes blink? You never met a snake. Snakes don't blink. Right? So they have a serpentine look. Face does not fluctuate with the expression. So what is that called? Mask face. Muscles become rigid all over the body. Of course, that causes pain to the patient. Right? And where there should not be movement, there is movement. Tremors. And patient to initiate the movement becomes very difficult. For example, if a patient wants to walk, he will take a lot of willpower to start the walk. And even then, if he starts the walk, it will be not normal walk. There will be short steps and festinant gait, and he will be walking like this. Right? And then trouble is there. If he want to stop, he doesn't know how to initiate the program to stop. So usually when they're walking, they overshoot. they find it difficult to start walking, and once they start, they find it difficult to stop walking, because stop walking need to initiation of another program, motor program. Is that right? Then another thing, if you are really ruthless, you just push them a little, they'll fall like a pole, because before they can make the reflexes, they are down. Before they can initiate their, normal reflexes. Is that right? If you ask them to write something, right, you will find, they will write like this. I'm patient of, what is this? They start with big writing, with spidery because of tremor, and during writing of the one sentence, they become so difficult, their willpower is lost, and progressively word become small. They don't have the enough power even to maintain the scale of the words. That is called micrographia. Life is difficult for them, right? Even for them just to open a button of their own shirt becomes a big thing for them. Is that right? Now, this is the problem in Parkinson's disease. But Parkinson's disease is usually age-related, and we don't know exactly what is the mechanism. They believe in some cases it is inherited defect. Some proteins are produced, or neurons are more vulnerable to environmental toxic substances. Some people believe that not only inherited factors are there, but there's a very powerful role by the environmental factors. Which factors? We don't know. But we believe there are some oxidant factors or hydrogen peroxide or some other neurotoxins which specifically damage the Nigrostriatal pathway, and these neurons are progressively lost and dopaminergic deficiency develop there. But Parkinson's-like syndrome can also develop due to some other problems. For example, if I give you drugs which can block dopamine receptor, the antipsychotic drugs are anti-dopaminergic drugs. Typical antipsychotic drugs are the dopamine receptor blockers. If you give me heavy dose of, I'm a healthy person, but if you give me heavy dose of antipsychotic drug, that drug will block dopaminergic receptors here, and if these receptors are blocked, it is the equivalent of having Nigrostriatal pathways deficiency. And until these receptors remains blocked, I will develop some abnormal motor activities which are called extrapyramidal side effects of antipsychotic drugs. Many patients on antipsychotic drugs develop features like Parkinson's disease. Is that clear? Another interesting thing. Yes, some more. Before I start the drugs, I would like to mention some other motor problems related in this area. Right. As I told you, that in different part of the basal ganglia system, different type of motor programs are present. Have you heard that some people who develop pathology in basal ganglia and then they develop chorea? I'm not talking about North Korea. I'm talking about chorea, C-H-O. What is chorea?
Sounds like movement. I don't know.
Can you show me that movement?
No, I can't.
Anyone can come here and show choreiform movement? Have you seen Michael Jackson in action? What is chorea? Chorea is basically purposeless jerky movements, uncontrollable. Patient cannot stop it. Does that remind Michael Jackson or not? Is that right? Why this occurs? First we make an analogy. Let's think of something. Before I explain how chorea occurs, let's think of some imagination. You go to a very big public library. There are thousands and thousands of the books in the cupboards. What you will do? Hopefully, you will go to one cupboard, take the book which you need, and open that book and read. Is that right? So you will run that book program. But if some earthquake comes, pathology occurs in library, most of the almiras and cupboards fall here and there, and most of the books are scattered there, and many books are open. This is a haphazard thing. This is exactly what happens in chorea. That this is motor program library here, especially in caudate nucleus and putamen. This is a motor program library. When some pathologies occur in these areas, what happens? Thousands of the motor programs start running automatically as thousands of the books are open needlessly. Is that right? So what really happens when there's pathology in this part of basal ganglia, caudate and what is this? putamen, thousands of the motor programs start running down. And they make all unwanted movement, purposeless movement, involuntary movement. So what is chorea? Chorea is a problem when there is pathology in the basal ganglia. Due to that, thousands of the motor programs are spilling over, not in a selected fashion. For example, there is one motor program for waving, other motor program is scratching, even though no hair, another motor program to eat, another motor program to handshake. But if all of them start running automatically, every program, you will develop chorea. You understand it? So when next time you think of chorea in your life, or you see a patient with choreiform movement, you must think there's something wrong with basal ganglia. You have heard of St. Vitus chorea, Huntington's chorea. These are all problems in which there is something wrong with basal ganglia. And Huntington's chorea, remind me, that's the right time to mention. In Huntington's chorea, these GABAergic neurons are degenerated. In Huntington's chorea, there is degeneration. That is an inherited disorder. You will study later in pathology. In Huntington's chorea, there is some genetic defect in DNA, and there is formation of abnormal protein called Huntingtin. And that protein lead to the gradual loss of GABAergic neurons and cholinergic neurons within basal ganglia. And that lead to choreiform movement. That is called Huntington's chorea. Have you heard of St. Vitus dance? St. Vitus dance you never hear. You only think of the dance by Paris Hilton or things like that. You don't ever think of Saint dance, St. Vitus dance. That is a disease, that is a problem, choreiform movement in a patient with rheumatic fever. Have you heard of rheumatic fever? Okay, thank God. So there is something called rheumatic fever, and in rheumatic fever sometimes basal ganglia are involved. And patient develop choreiform movement, and that is called St. Vitus dance. Again, the problem is where? In basal ganglia. Is that right? Okay, so we can say this area of basal ganglia injured, and that end up into what? Chorea, and chorea is Michael Jackson dance. I hope he does not sue me. Anyway, right? So no problem. Another thing, look, attention. In this area, there are raw motor programs. But when you want to do a movement, as connections are funneling towards the final pathway, they are refined. Let me tell you. Let's suppose there's a cup of tea here, just imagine, and I want to drink it. Do you think I will bring cup of tea to my mouth like this pathway, or I will bring it like this pathway, or I will bring it like a smooth pathway? Smooth pathway, isn't it? Actually, when motor program was initiated, it could be like this or it could be like this. But actually, this pathway, the inner part of basal ganglia, smoothen out the movements. It means motor program here are raw and here are refined, smooth. Is that right? Now imagine another patient who does not have problem in this area, who has a problem in this area. What that person will do? His abnormal movement will not be jerky movement like this. What will be his movements? What is this? Indian dance. But doctors call it athetosis. Have you seen Indian dances, classical Indian dances, Kathak dance? You see that like this, sinus, slow, rhythmic movements? You never saw that. Actually, those movements occur when there is problem here. And that is called athetosis. What is that called? Athetosis. Athetosis. What are athetosis? Athetosis are again abnormal movement due to basal ganglia problem. But in this case, patient has spontaneous, semi-purposeful, slow rhythmic movements. Is that right? So you can say chorea is like Michael Jackson dance, athetosis is like Indian classical dance. Is that right? Some people develop damage here. This area, subthalamus, has a very special function. Listen. Whenever you want to make any movement of the arm or movement of the leg, even fine movement of the leg, Do you think when you are making movement of the arm, the tone in this area should be adjusted or not? Try it. You do any movement and you will find the tone in this area will be changing. Actually, subthalamus is very much responsible to adjust the movement in this area and in this area, especially around the shoulder girdle and adjusting the tone in hip girdle. Is that right? Now you imagine an unfortunate person in which there is damage to this area. This is one of the very, very dramatic, one of the most dramatic presentation in clinical medicine. The person wake up in the morning and at midnight somewhere, the artery which was supplying this area, subthalamus, that ruptured or thrombosed. This occurs in diabetic patient very often. And he will have one of the very dramatic presentation. You know what will happen? Here are the program for the shoulder and the hips. I'm not going to show you that movement. Some Arabic dancer woman can show. She will have very special type of movements of the hips and the shoulder and area around the shoulder, right? That movement, right, uncontrolled ballistic movement related with the hip girdle and the shoulder girdle, right, that is called hemibalismus if it is on half side of the body. If both sides of the body, that is called balismus. You can call it Arabic dance. Why we call it balismus? Because arm go like a, this is not chorea, look. In chorea, arm is bending also. In this case, problem is in this area and this area. I'm not going to show you that movement, right? I'm very determined. But you imagine that there is unusual type of chest movement and hips movements and arms are moving in a flailing way, right? Those movements are called, if they are half the body, hemibalismus. If both subthalamus are gone, balismus, or ballistic movement. Is that right? Am I clear to everyone? So how many situations related with the basal ganglia you are clear? If this outer part of the basal ganglia, caudate and putamen are disturbed, you get choreas. If inner part of basal ganglia are disturbed here, you get athetosis. If subthalamus is disturbed, you get hemibalismus. And if nigrostriatal pathway is lost, you get Parkinsonism. Let's have a break now. Right, so we were talking about the pathology of Parkinson's disease and abnormal neurotransmission and what are the strategies for the treatment. The strategy for the treatment is that we should correct the neurotransmission imbalance in the basal ganglia. As we have discussed previously, the real problem is that dopaminergic activity is reduced in basal ganglia and unfortunately uncompensated cholinergic activity is excessive. Is that right? And this imbalance is produced due to progressive degeneration of the neurons in nigrostriatal pathway. Is that right? Now, disease has two levels. First level is that there is some unknown neurotoxic substance and these unknown neurotoxic substances are attacking the cell bodies of the dopaminergic neurons in basal, in the substantia nigra. In the substantia nigra, in pars compacta, there is attack of the neurotoxic substances yet to be identified, right? And these neurotoxic substances are leading to the progressive loss of nigrostriatal dopaminergic neurons. Up to now, we don't have any very effective drug which can arrest the progressive loss of neurons. And of course, up to now, we do not have any drug which can lead to the restoration of number of lost neuron. So because we don't have any drug to restore the number of neurons, so we say we don't have any curative drug for this disease. Number two, because we do not have any drug which can significantly reduce the progressive loss of neurons, so it means that our drugs which are presently being used don't really eliminate the further progressive loss. So what are the group of drugs we are using? Actually, the drugs which we are using currently are just trying to restore the dopaminergic and cholinergic balance within the corpus striatum, right? What are those drugs doing? These drugs are increasing the dopaminergic activity and trying to decrease the cholinergic activity. By using such kind of drug, which can increase dopaminergic activity in striatum and which can decrease the cholinergic activity in the striatum, actually we are trying to restore the transmission balance, right? If you restore this neurotransmission balance, what really happens that symptoms due to reduced dopamine are eliminated, or at least those symptoms are somewhat alleviated. What are those symptoms due to reduced dopamine? That is mainly akinesia or hypokinesia. And of course, when we use anticholinergic drugs, what we do? That we are trying to reduce the symptoms which are due to excessive cholinergic activity, and those symptoms are tremors and rigidity. Right? So whenever you use anticholinergic drug, you reduce the tremors and rigidity. But if you use dopaminergic drug effectively, it means that dopamine activity, if it becomes equal to cholinergic, then all the symptoms will be eliminated. Am I clear? So when you start dopaminergic activity, first of all, akinesia is eliminated. But when dopaminergic activity comes into balance with acetylcholine, all the symptoms will be eliminated. Is that right? Now, I will go into detail how these drugs are working. First, we will look at how the dopamine turnover is at this place. So let me draw only this area, how this area is working or this area is working, because real symptoms are produced from dysfunction in these two areas, right? And as our drugs are only eliminating the symptoms, they are called symptomatic drugs. Now let's see for that. First, we'll see how we can increase the dopaminergic activity. I will draw a dopaminergic neuron. This is substantia nigra. This is the neuron going up. Let's suppose this is the neuronal terminal button. It's out of proportion, right? And this neuron is ending up into another neuron, and this neuron is, yes, which one? GABAergic neuron. Is that right? This is releasing dopamine there. And other neuron which was coming over here was, yes, cholinergic neuron. And here we have to restore the balance. And this site is, this whole system is present in corpus striatum. Right. Now how we can increase the dopaminergic activity? First way is that we increase the synthesis of dopamine. We help the remaining few neurons to upgrade their capability to synthesize and release dopamine. How can we do? First, we should understand how normally dopamine is synthesized, right? The story starts from your GIT. From the GIT, you know, you are eating proteins, right? And amino acids are absorbed from the GIT, many amino acids, to the portal blood. And these amino acids pass through the liver, and eventually they appear in general circulation. These amino acids appear in general circulation. But for any substance to reach from the blood to the neurons, it has to pass through a barrier. What is the name of that barrier? That is called, yes, blood-brain barrier. Let's suppose this line represents blood-brain barrier. Primarily, blood-brain barrier is made by the cerebral blood vessels, capillaries which are having very tight endothelium, and every substance cannot go easily. Substances need to be properly transported. Is that right? Now let's start. How this neuron will synthesize dopamine? Actually, from the GIT, the substance which is absorbed from here is tyrosine. Is that right? And this tyrosine will appear into blood. Is that right? And at the same time, phenylalanine is also absorbed from the GIT and convert it into tyrosine into liver. So eventually tyrosine appear into blood. From the blood, tyrosine is transferred to through the blood-brain barrier into interstitial fluid into which neurons are dangling in the brain. Now when tyrosine is present over here, this tyrosine is actively transported into where? Nerve terminals. Actually, all the nerve terminals which produce dopamine or epinephrine or norepinephrine, they are having pumps to capture the tyrosine, because tyrosine is a precursor for formation of dopamine, norepinephrine as well as epinephrine. Is that right? Anyway, once tyrosine comes in, right, it is acted upon by a enzyme, right? And this enzyme is called tyrosine hydroxylase. What is this enzyme called? Tyrosine hydroxylase. It converts tyrosine into dopa. It converts tyrosine into dopa. Then there is another enzyme in second stage, and that enzyme can convert dopa into dopamine. Right? Now look, to convert dopa into dopamine, right, what process is required? Decarboxylation of dopa. Out of dopa molecule, we should get carbon dioxide out. So this enzyme which is present over here, this is called dopa decarboxylase. The enzyme, this is very important enzyme, right? This is called dopa decarboxylase, right? So it gets a carbon dioxide out of dopa, and what is left behind is dopamine. Now, there are special vesicles here, and these vesicles are special transporters. As soon as dopamine is formed, this is actively transported into this vesicles, right? Now this is dopamine. Let's suppose these are dopamine molecules. They are being concentrated into these storage vesicles. Now you may be thinking, why dopamine is not allowed to stay outside into cytoplasm? Why it is being stored into vesicles? Is there any reason, or just neurons likes to work, Carlos?
Yes, there is a monoamine.
Excellent. There is an enzyme here. You know, there's a lot of synthetic activity going on. We need a lot of ATP here, and there is mitochondria here. On the outer surface of mitochondria, there is a very special enzyme, and name of this enzyme, it is very bad intention. This enzyme is called monoamine oxidase. This is present on the outer surface of mitochondria, which are present in the nerve terminal. What they love to do? They love to damage the monoamines. What are monoamines? Neurotransmitters which are derivative of single amino acid. What are those neurotransmitters? Dopamine, norepinephrine, epinephrine, serotonin, histamine. These are the neurotransmitters which are derivative of single amino acid. And these neurotransmitters can be destroyed by enzymes called monoamine oxidases. Monoamine oxidases are present within the presynaptic nerve terminals. So, as soon as we make the dopamine, we don't want that this naughty man destroy that, so we capture it and store it in the vesicles. Is that right? No problem up to here. Now, when action potential comes, you know, when action potential is moving on this neuron, of course, action potential lead to depolarization and sodium influx. But when this wave of depolarization reaches to the nerve terminal, when wave of depolarization reaches where? To the nerve terminal, there are depolarization sensitive calcium channels, right? And depolarization opens these depolarization sensitive calcium channels, and calcium come in. So whenever action potential come to any nerve terminal, calcium influx will occur, including in these dopaminergic nerve terminals. And when calcium will go in, what calcium will do? Now take care. Actually, these vesicles are having a special type of calcium special type of proteins, and their corresponding proteins are present over this area. Right? These proteins are usually like this, and this cannot dock into this normally. But as soon as calcium comes in, calcium binds at this point and this point, and both calcium repel each other, and this mouth opens. Right? This protein is called synaptobrevin, and this is called syntaxin. So it opens its mouth. When it opens its mouth, right, this point will fuse with this, right? And when this synaptobrevin of the vesicle will fuse with syntaxins of the nerve terminal membrane, these proteins like actin, myosin interact and fuse the vesicular membrane with the terminal membrane. And when these two membranes fuse together, right, what will happen? What will happen? There is a release of dopamine. So then dopamine is coming out. Is that clear? Because every step will be affected by the drugs, so we have to see it properly. When dopamine comes out, what it is going to do? It will act on post-synaptic membrane loaded with dopaminergic receptors, and of course they will interfere with the intracellular G protein action. So dopamine will bind with either D1 or D2 receptors, and those receptors will give intracellular signaling and alter the excitability of the next neuron. But once dopamine come out, right, this dopamine, after it has done its action, it is recaptured by the, what is this? Special pumps, right, which will take the dopamine back in. This is called, what is this called? Reuptake 1 mechanism. What is it called? Reuptake 1 mechanism. This mechanism is present on all monoaminergic neuronal terminal. What are monoaminergic neuronal terminal? Nerve terminals of epinephrine, nerve terminals of norepinephrine, nerve terminals of dopaminergic neurons, nerve terminals of serotonergic neurons. Right? The duty of this uptake mechanism is that whatever extra monoamines are present here, or dopamine is present here, it should be recaptured. Some of this dopamine may be destroyed by monoamine oxidases and lost, right? But most of it is again restored. So this is, you can say, biological economy at molecular level, that we take the dopamine out, get the action on postsynaptic membrane, recapture it and restore it. And a small percentage which is lost, that is compensated by, again, synthetic effort, or synthetic machinery. Any question up to this? Now, the drugs which are available to us, number one is levodopa. Everyone knows levodopa, right? Levodopa is actually given orally. Levodopa drug is given orally. It will pass through the circulation. Through special pumping mechanism, it will cross the blood-brain barrier. Levodopa will appear here. Then levodopa will enter into, it will be taken up by the dopaminergic nerve terminals of the remaining neurons. Remember, many neurons have already been degenerated. So levodopa will be, whatever levodopa is going to the central nervous system fluid, it will be taken up by the, some of it will be captured by the nerve terminals of the remaining dopaminergic neurons in the striatum. And this levodopa will be acted upon by this enzyme. What is the name of this enzyme? Dopa decarboxylase. So this will rapidly convert the levodopa into dopamine, and the remaining neuronal terminal will synthesize excessive amount of dopamine, and then they will release excessive amount of dopamine so that they can make up for the loss of dopamine by the degenerated neurons. Is that right? This is strategy number one. Point number one is that what you are giving at this point. What you are giving here? Levodopa. Levodopa is a precursor molecule for the dopamine. So you can say you are giving half-cooked material so that neuronal terminal can rapidly cook the dopamine out of levodopa and dish it out. Is that right? Question is that why don't we give dopamine directly to the patient? Maybe if we give dopamine, it will be recaptured and easy. Maybe we want this enzyme to work a little bit. Or what? Why don't we give dopamine? Question goes to this young man.
Can't cross the blood-brain.
Dopamine is a highly polar compound. They cannot cross biological membranes. Have you heard of tablets of dopamine or tablets of epinephrine or norepinephrine or serotonin? You never hear of that because these all monoamine products are highly polar compound. They're charged compound. And number one, even if you give some dopamine from here, can it really absorb from GIT mucosa? Because anything which is going to be absorbed from GIT mucosa to the blood, that substance should be lipid soluble so that it dissolve into mucosal membrane. Mucosal membrane is made of cells and cells are having the lipid bilayer. So mucosal barrier is lipid bilayer. And any substance which is highly charged cannot dissolve into lipid. And any substance which cannot dissolve into lipid cannot be orally absorbed. So epinephrine, norepinephrine, serotonin, histamine, dopamine, as a group, all of them are highly charged molecules, so they cannot be absorbed from GIT. That is why I don't give them orally. Now you end up with this thing, okay, you are very much, you can say, adamant to give the dopamine by intravenously. Even if you give it, you will get all the side effects, but never get it across the blood-brain barrier. Because blood-brain barrier is again made of cells, and cells have the lipid membranes, again lipid bilayer. Right? And only those substances can cross blood-brain barrier which are highly lipid soluble or they are specially actively transported. Dopamine is not actively transported from this area. And it is highly charged, it cannot dissolve in. So ideal treatment should be dopamine, but this ideal just collapses on the ground because dopamine cannot cross the blood-brain barrier. Even if you give it intravenously, it will only produce cardiac stimulation and a lot of unwanted side effects. So dopamine is not the treatment choice for the patient with Parkinsonism because this will not reach at site. Levodopa is the choice because levodopa is less polar. It is less polar. It is more lipid soluble. It can absorb orally. It can go to the blood. And by special transporter mechanism, levodopa can be transported to the central nervous system. From there, levodopa can be concentrated by nerve terminals into the cytoplasm. And from there, acted upon by the enzyme, it can convert into dopamine, and then remaining nerve terminals have an excessive amount of dopamine so that dopaminergic balance can be restored there. Am I clear? So strategy number one is, what is this? Providing the central nervous system with levodopa, a precursor molecule for and enhancing the synthesis of dopamine. Secondly, what else you can do? You can use some drug which can do three things at a time. Imagine a drug which has multi-strategy drug, which somehow increases the synthetic pathway, somehow increases the release pathway, and somehow decreases the reuptake. Just imagine a drug which can increase the synthesis a little, increase the release also, more efficient release, and does not allow it to be recaptured. So concentration of dopamine will be better here. What is that drug? Which has these triple actions. Slightly increasing the synthesis, slightly increasing the release, and slightly decreasing the reuptake, so that synaptic concentration become better. Never heard of this drug? Okay, that drug is also antiviral drug. Now you must be able to tell me. Amantadine. Have you heard of amantadine? So strategy number two is, when you use amantadine, you are having three plans. Number one, increase synthesis. Number two, increase release. Number three, decrease reuptake. Am I clear? Then, there can be another strategy to handle this situation. Problem is, reduce dopaminergic activity at this site. The whole problem is that at this point dopaminergic action is less. Why don't you give some drug which can directly stimulate the receptor? If we give some drug which can directly hit here and stimulate this receptor, that can produce actions like dopamine. So that is the next strategy. Strategy number 1 was giving the precursor substance so that giving levodopa so that there can be more dopamine synthesis. Strategy number 2 was multi-action drug which slightly increase synthesis, slightly increase release, slightly decreases the reuptake, amantadine. Now strategy number 3. What is that? Give a drug which will directly stimulate dopaminergic receptors. These are dopamine receptor agonist, a drug which can bind with dopamine receptor and also stimulate the receptor. Is that right? Can you tell me the name of few drugs like this which can directly stimulate the dopamine receptor? There are many, but we are just thinking what could be the strategies. Yes. Why don't you tell me bromocriptine? Bromocriptine. Pergolide. These are two dopamine receptor agonists which are derivative of ergot alkaloids. And then there are their new friends which are not derivative of ergot. And their new friends are, yes, who will tell me? There are two new friends in this group which can directly stimulate the dopamine receptors, but those drugs are not ergot alkaloids. Yes, anyone? You're not interested to tell? If you are sure you don't know, I can offer some prize. Okay, maybe you answer. I don't want to take risk. Pramipexole. Right? I will discuss every drug in detail later. I'm just telling you what are the different strategies. One strategy is give the drugs which can directly stimulate dopaminergic receptors, in which the classical drugs are bromocriptine and pergolide, and modern drug recent introductions are pramipexole and ropinirole. I don't know from where they find these names. Ropinirole. Right? These drugs are directly stimulating dopaminergic receptors. Is that right? Am I clear? Then we can talk about another strategy, that why don't you reduce the destruction. Let's suppose you increase the synthesis, or increase synthesis release and decrease uptake, or you use the drugs which directly act here. Now come to another strategy. Whatever dopamine is there, don't let it be destroyed. There are two pathways for dopamine destruction. One pathway was presynaptic membranes take up the dopamine. Most of it is restored, but some of it is destroyed by monoamine oxidases. In the same way, some dopamine may be taken up by postsynaptic membranes. And there is another enzyme waiting there. What is the name of that enzyme? Yeah, catechol O-methyl transferase. An enzyme which can transfer the methyl to catechol ring. What is the function of this enzyme? Catechol O-methyl transferase. It does methylation of catechol ring. Now you must be thinking, what are catechol rings? Do you know what are catechol rings? Oh my God, look. This is benzene ring. I hope all of you know that. At carbon number 3 and 4, if there is hydroxylations, this is called catechol ring. This is catechol ring. And with this, if you put ethyl group, what is this? With this catechol ring, what you are putting here? Ethyl group. And if you put here amino group, what is this now? Basic structure. Catechol ethyl amine. People write such molecules catecholamines. Have you heard of something called catecholamines? All catecholamines have basic this structure. You think of epinephrine, norepinephrine, or dopamine, all of them are catecholamines. All of them have catechol ring. And this naughty man, what this naughty man does, it try to eat, what is this? This hydroxyl. Remove this hydroxyl and put their methyl. So what should be the name of this enzyme? It takes the catechol ring and add a methyl group. So we call it catechol O methyl transferase. What does it all tell you? It tells you this enzyme will do methylation of epinephrine as well as norepinephrine as well as dopamine. Am I clear? No problem into this. So catechol O methyl transferases, these enzymes are present in liver, these enzymes are present in GIT, they're present in many parts of the body, including in postsynaptic membranes. Right? So when they take up catecholamine may be dopamine or epinephrine or norepinephrine and lead to that methylation. When you remove this hydroxyl and put methyl, this molecule become dysfunctional. So that is another way to destroy catecholamines, of course including dopamine. Now the next strategy should be, we are losing the dopaminergic neurons, they are progressively undergoing degeneration and we want the remaining neurons work more efficiently. One way is that reduce the destruction of dopamine. How you can reduce the destruction of dopamine? Inhibit this or inhibit this, and if you are really intelligent, inhibit both. That's so simple. There's no fun in making more and more dopamine and which is getting destroyed. If you are really a good strategist, then you should increase the synthesis and decrease the losses so that remaining neurons work more efficiently. Is that right? So now there are tablets coming in combo for the Parkinson's patient, which not only have levodopa to increase the synthesis, but they are also having drugs which inhibit the monoamine oxidases and also have drugs which inhibit COMT. Here it's worth mentioning that monoamine oxidases are of two types. Monoamine oxidases. There are two types of them. One of them are little bit serious and others are very much friendly. Actually, this is called monoamine oxidase A and this is called monoamine oxidase B. Monoamine oxidase A destroy monoamines. Monoamines mean what? Neurotransmitters, the substances derived from single amino acid. Right? Monoamine oxidase A it loves to destroy epinephrine and norepinephrine. Epinephrine, norepinephrine, and of course serotonin. Serotonin is 5-hydroxytryptamine, which is a derivative of amino acid called tryptophan. Right? Monoamine. So monoamine oxidase A destroys the epinephrine, norepinephrine, and serotonin. And monoamine oxidase B is happily busy in destroying dopamine. And we are also very happy because these two enzymes are slightly different. So we have the drugs. If in Parkinson's disease, what kind of monoamine oxidase inhibitors you will use? You would like to block both of them or one of them? In patient with Parkinsonism, if I give you drug, this is drug number 1, which can block the monoamine oxidase A as well as B. You would like to use this one or you would use another drug which can only block the action of monoamine oxidase B? Only B. Because if by mistake you give a drug which will block the monoamine oxidase A and B both, that is called non-selective monoamine oxidase inhibitors. They're very bad because when non-selective monoamine oxidase inhibitor block both of them, of course dopamine level will go up, but unfortunately epinephrine, norepinephrine, serotonin levels will also go up. That will produce side effects, unwanted actions. So now we have drugs which are more selective at low doses or at therapeutic doses to block the action of monoamine oxidase B. So dopamine level in the neurons is going up so that when dopamine comes back to home, it is not destroyed, and it will be recaptured and restored more efficiently in higher concentrations. Of course, name of the drug you must be knowing. What is the name of drug? Pardon? Pardon? Carbidopa. Yes, carbidopa, but that work more in the peripheral part. And secondly, write down carbidopa and put a very, very big cross on it. You are trying to confuse me, my friend. He thought he remembered one drug, he should mention it. Listen, carbidopa is blocking dopamine decarboxylases in the peripheral tissue because carbidopa cannot jump around blood-brain barrier. We'll talk about that in a big way, right? So, not carbidopa. Yes, you understand? Carbidopa is a drug which blocks the dopa decarboxylase enzyme. Is that right? That is not right now relevant with us. Right now we are talking about a drug which is capable of blocking the enzyme monoamine oxidase B inhibitors so that dopamine should not be destroyed. And name of the drug you must be knowing. Pardon? I don't know what you are telling. Okay. He is trying to impress me with some name which no one has heard. Right. Oh, this is simply called selegiline. Have you heard of selegiline? Selegiline actually blocks this. Selegiline. This is strategy number 4. This is strategy number 4. Selegiline. We'll discuss every drug in detail later, but first develop a big picture. That's what we are going to do it. Either you increase the synthesis by giving levodopa, providing more levodopa at nerve terminals, or you increase synthesis, storage, release, and reduce reuptake by amantadine, or you directly stimulate the receptors by dopamine receptor agonists like bromocriptine pergolide, which are ergot derivative or non-ergot derivative, pramipexalon and ropinirole. They are too new that I don't know them well. Anyway, why it is so important? I'm again saying these are ergot derivatives. These are not ergot derivatives because ergot derivatives have a lot of side effects and non-ergot derivatives have less side effects. Then I said there should be drug. Yes, there should be some drug which basically reduce the destruction of dopamine. Dopamine is destroyed by two types of mechanism, either by monoamine oxidases or it is destroyed by COMTs, right? Monoamine oxidase B specifically is more interested in destruction of dopamine as compared to other monoamines. And we have luckily having a selective monoamine oxidase B inhibitor. The name of the drug is selegiline. The name of the drug is selegiline. Is that right? Now, after that, we come to a drug which will block action of catechol O methyl transferase. Now we are talking about a drug which can block the action of catechol O methyl transferase. And who will tell me the name of that drug? Don't tell me Tolcapon. You know Tolcapon? You don't know Tolcapon? In Chicago, he used to be there, I think. So don't tell me that. That is not name of drug. Actually, name of drug which destroys COMTs are also probably from the family of Tolcapon. I don't know, somehow they name like that. Maybe to honor that family, they're putting the name of the drugs on capon. For example, the drugs which inhibit the catechol O methyl transferase, they are called Tolcapon. Tolcapon. So I told you don't say Tolcapon. This is Tolcapon, right? Another drug like this which does not act in central nervous system but in the periphery, that is called Entacapone. So we can say the strategy number 5 is inhibit the COMTs, right? That also reduces the destruction of dopamine, especially in central nervous system. The drug is Tolcapone. Tolcapone. Is that right? Now, Again, how many strategies you have? As many fingers you have in your hand up to now. These are the 5 mechanisms which can they can be used to increase the dopamine concentration and action, dopaminergic action in striatum. Number 1, give the levodopa, increase the synthesis. Give the amantadine, increase the synthesis, storage, release, and decrease the reuptake. Give the direct stimulator to the dopamine receptors, like, at least see and tell me, like bromocriptine and pergolide, ergot derivatives, or non-ergot derivative like pramipexole and ropinirole, or reduce the destruction of dopamine by inhibiting monoamine oxidase B. Drug is selegiline and its friends. And then you can use the last strategy to increase the dopamine activity is inhibit the COMTs, inhibit the catechol-methyl transferases. The group of drugs are not Alcapone, they are Tolcapon and Entacapone. We'll talk about that later. And of course, don't get too much messed up with all this dopaminergic. Remember, there is something cholinergic here. You can block also that. Is that right? Is that right? So, anticholinergic drugs are also used. That is strategy 6. Is that right? First 5 strategies are with increasing the dopaminergic action. And 6th strategy is reducing the cholinergic activity. Right? And that is, of course, it means this neuron has cholinergic receptors as well. So these receptors can be blocked. Anticholinergic drugs. What are those drugs? At least tell me one name, if not 5. Oh my God, atropine. Give something selective. Atropine is really too bad. It is too much atropine. Why don't you tell me benztropine? Benztropine. And actually there are 5 of them, but you should know 2 or 3 of them. One is benztropine. Other is biparidine, B-I-P-E-R-I, biparidine. This is also anticholinergic. And then you may be knowing your own friend, orphanadrine. Have you heard of orphanadrine? I think if this would have been names of girls, everyone will be knowing them. Orphanadrine. Right then? Yes. Procyclidine. Right? And one more. You have to find it yourself. Right? So these are the basic 6 strategies which are used to correct the neuronal transmission dysfunction in where? Striatum. Is that right? Again, rapidly. Either you provide more dopamine by increasing synthesis by levodopa, or helping that system to synthesize, release, and reduce uptake by amantadine, or by directly stimulating the receptors here by bromocriptine and its friend, or by reducing the destruction by monoamine oxidase like selegiline, or reducing the destruction of dopamine by inhibiting COMT like Tolcapon. And of course, you will not forget, you're having good memory, that anticholinergic drugs can be used. Let's have a break. Today we will discuss drugs used in Parkinson's disease in detail, right? And let's review the strategy first, and then we'll go take the drug one by one, right? You remember that main problem is that there is decreased dopaminergic activity in the striatum due to degeneration of Nigrostriatal Pathway. And of course, there is uncompensated excess of cholinergic activity. And we have to balance this neurotransmitter dysfunction, right? So let's review our strategy and then we'll move forward. Let's suppose that here was your central nervous system, and here was your dopaminergic neuron in which part? Substantia nigra, and it was being projected to striatum, and there it was releasing dopamine, and these were your GABAergic neurons there. Is that right? And here was that GABAergic neurons were under influence of cholinergic system as well. And we have to correct this balance. We have to enhance the dopaminergic transmission and we have to decrease the cholinergic transmission. I will draw this structure, this part larger here. That let's suppose here is your dopaminergic neuron and this dopaminergic neuron is, yes, now winding, isn't it? And here is your GABAergic neurons, and of course there is no fun in telling that what are these neurons? Cholinergic neurons, right? Let's recap the synthesis, transmission and strategies and then we'll discuss the drugs over here. You remember we were taking up which substance from the blood? Tyrosine, right? Tyrosine was taken in, converted into, yes? Dopa, very good. And dopa was converted into dopamine and dopamine was concentrated in vesicles. And then these vesicles which are loaded with the dopamine on influx of calcium, they will release dopamine and this dopamine will act on which receptors? Dopaminergic receptors, which are 7-pass receptors coupled with G, intracellular G proteins. So presynaptic membrane synthesize, store and release dopamine and postsynaptic membranes have dopaminergic receptors. After the dopamine has done its action, right? I'll make these arrows green so that you don't confuse them. Dopa into dopamine and now dopamine is being stored and here it is released. Here it starts its action. Right, then what happens? That this dopamine, right, it has to be recaptured. That was reuptake mechanism number 1, right? And this dopamine, once it is recaptured, it appears in, right? It is vulnerable to destruction by which enzyme, please? Right? That enzyme is called monoamine oxidase. Monoamine oxidase, especially B, right? And this either it will escape the enzyme and it get recaptured and restored, isn't it? Or it will be destroyed by enzyme into breakdown product. So one destruction pathway is monoamine oxidase B, other was, yes, COMT, catechol O methyl transferase, right? And this one is monoamine oxidase B. So either it is destroyed by dopamine, is destroyed by monoamine oxidase pathways, or it is destroyed by COMT into breakdown products. Is that right? Now what we discussed, the initial strategies of management was, point number 1 was what? That we provide here. What we do? We provide the precursor drug. That was levodopa, excellent precursor drug. Second was that second strategy is use a drug which will increase the synthesis, increase the release and decrease the reuptake. That is drug which will increase synthesis, positive effect on synthesis, increase the release but negative reuptake. What was the name of the drug here? Yes, amantadine. Important point about amantadine is it works only for few weeks. Once you start amantadine, it has a mild effect on dopaminergic transmission in striatum system, but its action lasts only for few weeks or months, then drug becomes useless, and that is why amantadine cannot be used for very long. Another point related with amantadine is that primarily this drug is anti-viral drug. Against which virus it is used? Influenza virus, influenza A virus. Amantadine is a drug which reduces the, if it is given early, it reduces the severity and duration of the influenza A related problems, right? Anyway, let's come back. Then there was strategy number 3 where we can give the drug directly which could stimulate the receptor. Is that right? These are called directly acting dopaminergic drugs, directly acting dopaminergic drugs, or we call simply dopamine receptor agonist, right? The drug which can directly stimulate here, you remember the class of that drug? What was the name of those drugs? Bromocriptine and pergolide, both of them belong to ergot group. And then there were, yes, pramipexole and ropinirole. Both of them were non-ergot direct dopamine receptor stimulator. You know, there's something very interesting about these drugs, non-ergot dopamine receptor stimulators, especially about pramipexole and ropinirole. What is any special thing about that? That they don't have the side effects of ergot alkaloids. They are modern drug and they are very rapidly replacing the ergot drugs. This is an important point because pergolide and bromocriptine, they are derivative of ergot alkaloids, and ergot alkaloids have a lot of unwanted actions. So pramipexole and ropinirole have their own side effects but not ergot side effects, and their own side effects are far less than ergot side effects, right? Then we said that strategy number 1, 2 and 3 discuss strategy number 4. You give the drugs which will inhibit monoamine oxidase B, right? The classical drug here was selegiline, is that right? And then we can give the drugs which inhibit, yes, what is your friend name? COMT inhibitors and catechol-O-methyl transferase inhibitors are called, yes please. This was Tolcapon family, isn't it? The drugs name were Tolcapon and Entacapone, right? So these were basic strategies. Now we will discuss one by one drugs used in different strategies. Let's suppose put here your, yes, circulatory system. Here is your circulatory system. Right, first thing you have to remember, any drug which has to act on these neuronal system has to pass the blood-brain barrier. And when we say these drugs have to pass the blood-brain barrier, we must know that blood-brain barrier is what? You will tell me. What is blood-brain barrier? This is made by specialized endothelial cells which are lining the cerebral vessels, and these endothelial cells have very much tight junctions and they allow only selective substances to enter into central nervous system from cerebral capillaries. So many substances from the general circulation don't enter into central nervous system interstitial area or private area where the neurons and glial tissue work, right? Many substances don't enter, right? Why these substances don't enter? Because endothelial cells there are very tightly junctioned with each other, and in this way we are creating a private and microenvironment for the function of neurons and glial tissue, right? Usually the substances which do not enter are those which are large molecular weight or which are highly polar compound. What does it mean? That all the drugs which act on the central nervous system must be either highly lipid soluble and or non-polar compound. Is that right? Am I clear to everyone? Now, when we talk about the drugs which are acting on the okay, let's make it like this. Suppose this is here is your GIT, right? Of course, these are your mucosal cells, isn't it? They are producing another biological barrier for the entry of the drug from the GIT to the circulation. Of course, all of you must be knowing the drugs which have to absorb from the GIT before going to the general circulation, they are absorbed into which circulation? Portal circulation, and then through the portal circulation they pass through the liver and eventually drain into general circulation. There's no fun in telling that this is basically which vein? Hepatic vein. These are hepatic sinusoids, and these are of course portal vein collection. Right, now we start with the drug. First of all, we'll talk about the most classical drug, which is levodopa. I think it's a little bit suspicious diagram. It reminds me of something. Okay, now it becomes good. or even more dangerous. Right, levodopa. Levodopa. Levodopa is a precursor, immediate precursor of dopamine. Right? It is levorotatory stereomer of dopa. Is that right? And levodopa is basically a compound which can be acted upon by dopa decarboxylase and converted into dopamine. Is that right? Now, the first question which we have to answer is that when we give, why don't we give the dopamine directly? I think in last lecture we discussed. Because we don't give dopamine directly, because number one, if you give dopamine directly, it will not be absorbed from GIT properly, because it is highly polar compound. Is that right? Number two reason, that even if you inject the dopamine directly to the blood, it will not cross blood-brain barrier again, because it is highly polar compound. That is why the dopamine is not used as a drug for the treatment of Parkinson's disease. Now we come to the levodopa. Levodopa is more lipid soluble. Right? No need to remember it. Any drug which is going to central nervous system must be highly lipid soluble, can be taken orally, must be crossing the placental barrier. This is a basic principle. Any drug which is going to the central nervous system, which has a capability to cross the blood-brain barrier, must have a capability to cross the mucosal barrier, must have the capability to cross the placental barrier. Is that right? Anyway, levodopa is less charged compound, right? So it can be easily and rapidly absorbed from GIT. It can be easily and rapidly absorbed from GIT. But at this point, there are a few important things to be discussed. Levodopa absorption is very strongly affected by the food. It should be taken empty stomach. Ideally speaking, levodopa should be taken about 1 hour to 40 minutes before food, before taking the meals, because its absorption is affected by the gastric emptying, its absorption is affected by the gastric pH, and the most important point is that levodopa absorption is affected by the presence of neutral amino acids, because this absorption mechanism here, which is used by the levodopa, is also used by neutral amino acid. Can you tell me some neutral amino acid? At least tell me leucine and isoleucine. Right? Am I clear? So when you will take heavy meals, especially protein-rich meal, then amino acids will be busy through this pathway and levodopa will not be absorbed well. So what does it mean? The protein meals should be taken by these patients preferably at night, because in the daytime, if they are taking heavy protein meals and levodopa is not absorbed well, patient is not getting the action of the drug on the central nervous system, and patient is least happy, because in spite of taking the drug, patient is having still hypokinesia, akinesia. And of course, during the sleep, you don't need to be much kinetic at night, right? So you can afford that if you have a patient who is a protein lover, you can take heavy proteins before and in the dinner, not in the lunch, right? Because if he does not absorb the last dose of levodopa well, it doesn't matter at night, he doesn't need that much levodopa, I suppose. Am I clear to you? Right? Another thing, not only this transport mechanism here is involving the competition between levodopa and the neutral amino acids, you will be surprised that the drug is transported from here also by the same mechanisms. Drug passes through the blood-brain barrier also by the similar mechanisms. So again, there is a competition between your friend and amino acids and levodopa. It means it's better the drug should be taken 1 hour before the meal, so that before the meal starts its action, drug should be already in the central nervous system. Is that right? Am I clear? So this was the relationship, important relationship, that levodopa drug should be prescribed before meals or 1 hour to 40 minutes before the meals, right? And meals should not include heavy amounts of proteins, and if patient really loves to take proteins, then that should be dinner. Proteins should be given in, preferably in dinners. Am I clear? No problem. Now, second important point is that once levodopa is going through, of course, through what is this? GIT mucosa, and then through the liver, and eventually appearing in circulation, right? Actually, by the time it reaches to circulation, a lot of it is destroyed. Why it is destroyed? Because in the GIT and in the liver, there are special type of enzymes. You must be knowing the name of those enzymes. What are the name of those enzymes? Please recognize this enzyme. What is this enzyme? Yeah, monoamine, MAO. You know, MAO. These MAO enzymes, monoamine oxidases, are present, number one, in multiple area. Number two, there are many enzymes after this. There is another enzyme there, very important one. What is that? Yeah, who will tell me this enzyme? Yes. This enzyme, well, okay, let me tell you, it will convert the levodopa on the way into dopamine. Yeah, dopa decarboxylase in the peripheral tissue. Excellent. What is the name of this enzyme? Dopa decarboxylase. It takes the levodopa and bring the carbon dioxide out. When the levodopa undergo decarboxylation, the remaining molecule is dopamine. So it means that lot of levodopa which is being absorbed from here, it may be acted upon by dopa decarboxylase, and then this levodopa may convert into dopamine. And do you think dopamine is a good compound?
No.
It is not. It is an unwanted compound. Why? Now this enzyme is doing two things. Number one, it is reducing the dose of levodopa available to the central nervous system. Number one, it is reducing the amount of levodopa which is going to be available to central nervous system. And number two, it is producing dopamine which is dangerous, right? This dopamine, you know, normally if you take 100 milligram of levodopa, how much levodopa will reach really to the central nervous system? Only 1 to 3%. If right now I give you the levodopa tablet, right, you will absorb it very well, but before reaching to the central nervous system, a lot of it will be converted into dopamine and some other compounds, and only 1 to 3% of the levodopa normally reaches central nervous system. It's a good news or bad news? It's very bad news, because you wanted action, and for action only 1 to 3% is there, and this is a wrong action, dopamine, because this dopamine will produce the peripheral side effects. For example, this dopamine loves to interact with cardiac tissue as well as vascular tissue. Vascular smooth muscle has dopamine receptors, right? Why? Because this dopamine will be taken up by adrenergic nerve ending. You know, heart has adrenergic nerve ending. Are you sure? SA node, AV node, and other area have sympathetic supply, and you know they release norepinephrine and then reuptake, and reuptake mechanism is promiscuous. Not only it has capability to reuptake epinephrine and norepinephrine, it can even take up have a chance take the dopamine. And do you think it's good or bad? Not only this reuptake mechanism will take in the nerve endings dopamine, convert them to norepinephrine and release. It's a bad news, because many sympathetic nerve endings will take up the dopamine, convert into norepinephrine and release it. Sympathetic drive may become more on the heart and cardiac arrhythmias may be precipitated. Now look at it. Less drug available for real effect, and more drug is being converted into a form which is side effect. This is a big problem. Secondly, number one, it produces cardiac arrhythmias. What type of cardiac arrhythmias? Any type. It may produce sinus tachycardia, it may produce atrial tachycardias, it may produce atrial fibrillations, it may produce extrasystole, depending upon how much dopamine is there, it may produce more and more dangerous type of tachyarrhythmias. Am I clear? Secondly, this dopamine may act on the D2 receptors on the vasculature, and D2 receptors are vasodilators. So many vessels may dilate, especially veins, and that may produce postural hypotension. That may produce postural hypotension. And here it was cardiac, yes, tachyarrhythmia, overstimulation, cardiac tachyarrhythmias. Am I clear? So these two side effects are unwanted actions are present in the peripheral tissue due to conversion of levodopa into dopamine. So this nasty enzyme, which is peripheral dopa decarboxylase, we are not happy with this enzyme. Why? Because not only it reduces the levodopa available for the central nervous system activity, but also it converts the levodopa into dopamine, which can produce peripheral side effects. Moreover, this dopamine, it can go to the chemotrigger zone. There is chemotrigger zone here. There is fourth ventricle here. Do you remember something like that? And in the floor of the fourth ventricle here is area postrema and chemotrigger zone. Now in this area, blood-brain barrier is broken. In chemotrigger zone and area postrema, blood-brain barrier is broken. Why it is broken? Because neurons there are sampling the blood for toxic substances. In a small area here, blood-brain barrier is broken. So whatever is present in blood, it can influence these neurons. And when dopamine reaches, of course, levodopa converts into dopamine and then reaches to chemotrigger zone, right? It stimulates those neurons and that produces nausea and vomiting. That produces nausea and vomiting. So do you think these are good news or bad news for the patient? Already patient was unable to move, having tremors and rigidity at the top. Now he develops hypotension, cardiac arrhythmias and nausea and vomiting. And even he cannot walk up to the basin to vomit really. It's a very pathetic situation, right? And only 1 to 3% drug is going to the central nervous system. Most of the drug is converted in the periphery into different product, including dopamine and producing side effects. So what should we do? We want that there should be less dopamine produced and more levodopa going to the central nervous system. What should we do? We should kill this nasty enzyme. What is this enzyme? Do you remember that? Dopa decarboxylase. Of course, we call it peripheral dopa decarboxylase. This is peripheral dopa decarboxylase, and we are having an enzyme for its action. Yeah, what is that? We have a special drug we can give with the levodopa, right? So that this levodopa this is a levodopa, it should escape. Is that right? This is levodopa now, and this was its dangerous form, right? Nasty form. Now, levodopa we don't want to be destroyed by this. So along with the levodopa, we give another drug. And what is the name of that drug? Okay, that is that drug. Hypothetically, I can show it by this way, right? Okay. This is a drug which is given along with the levodopa. What is this drug called? Carbidopa. Is that right? This is called Carbidopa. Now, how the carbidopa works? Actually, carbidopa will go along with the levodopa and work on this enzyme. Right? What carbidopa will do? Carbidopa will is that right? What it has done? So it has bound with the dopa decarboxylase and caught it. How is dopa decarboxylase now? very sad and maybe weeping, right? And its tail also has come down. Why? Because it is caught by, yes, it is caught by Carbidopa, right? So this is the function of Carbidopa. The Carbidopa loves to, yes, bind with dopa decarboxylase and make it ineffective. When Carbidopa binds with the dopa decarboxylase and reduces its activity, what happens? That production of dopamine is, yes, reduced. Production of dopamine is reduced, and levodopa available and going to the central nervous system is increased. Is that right? This strategy has two benefits. That with the levodopa, if you give the patient carbidopa, it has two benefits. Number one, due to reduced, when carbidopa is inhibiting the dopa decarboxylase, there is reduced production of dopamine. Of course, peripheral side effects are reduced. What are the peripheral side effects? Cardiac tachyarrhythmias are reduced, chances of that. Hypertension is reduced. Nausea, vomiting, and anorexia is reduced. These are the advantages of giving carbidopa along with the levodopa. Is that right? Plus, second advantage is that larger amount of levodopa is available to go to the central nervous system. Is that right? So, naturally beneficial effect of levodopa will be increased because then larger amount of levodopa will be taken up by the dopaminergic nerve, remaining dopaminergic nerve endings, and remaining dopaminergic nerve endings will be releasing more dopamine, and nigrostriatal system start working better, right? So that will remove that all the symptoms of, initially it removes all the symptoms of, eliminates all the symptoms of Parkinsonism at least in 1/3 of the patient. That is, bradykinesia is reduced, tremors are reduced, and even your rigidity is reduced. Am I clear? Now, but there is one thing very important to be discussed here. When you give carbidopa, the percentage of levodopa going to the central nervous system will increase from 1 to 3% to about 10%. It means still 90% of the drug is lost in the periphery. Now, actually there is another enzyme present in the periphery and which can destroy the what? Levodopa. So can you tell me what is that enzyme? Yes. This is another enzyme and it will take the levodopa and convert into, it will do methylation of levodopa. So we call it 3-O-methyl-dopa. What is this product? 3-O-methyl-dopa. I think it should be outside the central nervous system in the periphery. So I will draw it here. In the peripheral tissue, there is one more enzyme, right? What is the name of that enzyme? Yeah. So levodopa, when it is not destroyed by this, listen now carefully. Normally levodopa was going up and a lot of it was destroyed by dopa decarboxylase. So we have given carbidopa and inhibited this. Now actually the other pathway of its destruction comes into action and it becomes compensatorily more active, and this is called it is called catechol O-methyl transferase. Catechol O-methyl transferase is present centrally as well as in the periphery. What it will do? It will convert the levodopa into methylated form, and that methylated form of levodopa is called 3-O-methyl-dopa. Right? This methylated form, right? This is your original levodopa going, right? And this methylated levodopa, This is methylated. Now methylated levodopa cannot be converted into dopamine. Because it cannot be converted into dopamine, it means this is waste product. It's a waste metabolite. Basically, it in a way this pathway is destroying our drug. Now it's very funny that actually we were saving the drug from dopa decarboxylase and we have inhibited that by carbidopa, right? And now other pathway has become overactive, COMT pathway, and that start destroying the levodopa into methylated product, and not only destroy. Okay. In this pathway, what was happening? That not only levodopa was destroyed but converted into dopamine, and that was producing side effect. Here, one good news: this does not produce any side effect, but it does very bad thing. You know what it does? It also loves to go to the CNS, so it uses this pathway. So now there is a competition between levodopa and methylated dopa to enter into central nervous system. And due to this competition, again levodopa entry into central nervous system will be increased or decreased? Yeah? Decreased. So this is another tragedy that when doctors were initially, for many decades, we were using levodopa with carbidopa and hoping that big amount will go to central nervous system, but somehow there was some increase in levodopa availability in central nervous system, but not as significantly as we expected. Later on, we discovered that actually there is something naughty going on, that in the periphery there is another enzyme COMT which is converting levodopa into methylated form, which is useless as a precursor for dopamine, but this methylated useless product is producing trouble for us because in the blood-brain barrier, the transporters which take the levodopa from the peripheral blood to the central interstitial fluid, those transporters are also occupied by methylated form of dopa. Am I clear? So of course, if enzyme is naughty, we are more naughty. We came up with the drugs which could inhibit this enzyme. What is the name of that drug? Yes, anyone? The drug which can inhibit this COMT. Yes, please. Yeah, Tolcapon and Entacapone. Now I tell you something like Tolcapon and Entacapone. The two drugs, Tolcapon and Entacapone. Both of them can inhibit COMT, but there are a few things which you should remember about them. Tolcapon has L in its name. You know what it should remind you? It is toxic to L. L means liver. Tolcapine is toxic to the liver. This is number one thing. That is why usually we don't use Tolcapon. In USA, the use of Tolcapon requires written consent from the patient. Is that right? And you have to do again and again liver function tests, especially liver enzymes, when patient is on Tolcapon, right? Tolcapon is really tall enough because it goes up to the CNS. So Tolcapon inhibits the monoamine oxidase in the periphery as well as in the central nervous system. It inhibits the COMT. Tolcapon inhibits the COMT in the periphery as well as in the central nervous system. Entacapone does not have L, so it is not having liver toxicity. Number two, Entacapone had one more thing. It has one thing very important for us. It cannot cross the blood-brain barrier, so it works only on the periphery. Peripherally present COMT. Both of them are COMT killer. COMT killers, inhibitors. Both of these drugs are COMT inhibitors, right? But the point which you have to remember is Tolcapone is tall enough to go to the central nervous system because it is more lipid soluble. It can go there, and Tolcapone has L and liver toxicity. So what you will prefer for your patient? Entacapone. So actually these days we are giving Entacapone, and this Entacapone, this is This is Entacapone, right? And this Entacapone can inhibit the action of peripheral COMT. When action of peripheral COMT is inhibited, naturally bioavailability of levodopa to the central nervous system is increased. Is that right? And secondly, when methylated dopa is less, whatever levodopa is available, it does not have much competition to enter into CNS. Am I clear? So we have done two clever things to take the levodopa up to central nervous system. What are those two clever things? Now listen. Our central drug is levodopa, and we have to take it from GIT up to the central nervous system for its action. Problem is that if you give levodopa alone, only 1, 2 or 3% of the drug goes to the central nervous system. Most of the drug is acted upon by peripheral enzymes. For example, I think monoamine oxidase we should remove from here. We'll discuss that later. Mostly it is acted upon by this rat and this rat. These two rats are dopa decarboxylase and other rat is catechol-methyltransferases. So you can say levodopa is attacked by the rats. This rat dopa decarboxylase can be captured by carbidopa, and this rat COMT can be captured by entacapone. You have to get someone from Tolcapon family to catch this rat, right? Entacapone. When these two are caught, we have some benefits. What are the benefits? Number one, when carbidopa is working, levodopa is not converted into dopamine, so peripheral side effects are reduced and more levodopa available to the central nervous system. Secondly, when peripheral COMT is inhibited by entacapone, what happens? Now levodopa is not converted into methylated forms, so again more levodopa available into the central nervous system. Secondly, methylated form is not competing with the entry of levodopa to the central nervous system, so more levodopa is going to the central nervous system. All this is good or bad? All of this is good with some bad thing. If too much levodopa goes to the central nervous system, it will produce dyskinesias. Excessive dopaminergic activity produces abnormal movements. We were giving the levodopa to start the movement. Patient was hypokinetic, but we don't want to make our patient hyperkinetic. Is that right? So all this thing, when we block this one and that one and we keep the dose of the levodopa same, very high amount of levodopa goes to the central nervous system, and that may produce side effects in the central nervous system. We have reduced the peripheral side effect, but we have increased the central side effect. Central effect is that hypokinesia and akinesia should be eliminated. But if levodopa is too much going to the central nervous system and there is unwanted excessive dopaminergic activity in the central nervous system, that will translate into dyskinesias. What are dyskinesias? Now we are talking about central side effects of levodopa. What are dyskinesias? These may be dystonias. There are many types of dyskinesias. I think good students should know about that. What are dyskinesias? Dyskinesias or hyperkinesias. These may be tremors. This may be, yes, please. These may be chorea. These may be acidoses. These may be dystonias. These may be, what is this? Your akathisia, especially, rather than dystonia, write down akathisia. And lot of problems. So what really happens? Now listen carefully. If there's excessive dopaminergic activity on the striatum, that may translate into what? Dyskinesias. Dyskinesias are excessive abnormal movements. Of course, that is a side effect of our excessive levodopa, and that may be tremors, chorea, acidoses, akathisias, and other type of tics. Even tics can form. There's so many types of dyskinesias. Right? Do you think a patient will be happy? Previously, he was unable to move his arm, and now he is unable to stop his arm. Right? So, this is one problem. Secondly, dopaminergic pathways. Up to now in the lecture, we were concentrating on nigrostriatal dopaminergic pathway. But good students know that there is another very important dopaminergic pathway in central nervous system, which is called mesolimbic pathway. From midbrain up to the limbic system, there is a very powerful dopaminergic pathway. That pathway is mesolimbic system pathway. When there is excessive dopaminergic activity there also, because when levodopa will go to the central nervous system, of course, not only it will be taken up by the dopaminergic terminals and striatum, but excessive levodopa will be taken up by dopaminergic nerve endings in mesolimbic pathway. And when dopaminergic activity increases in the limbic system, that precipitate, yes, psychiatric complications. Limbic system is concerned with your emotions and behavior and mood. So what really happens, another group of side effects is there, that when basal ganglia are acted upon, that will lead to dyskinesias, and when mesolimbic system is under excessive dopaminergic activity, that may produce, yes please, that will produce what? That may produce anxiety. Start with the small thing and then go to psychosis. Excessive dopaminergic activity as progressively may produce more dangerous things. First anxiety, then it may produce, yes please, confusion. Then it may produce, yes, hallucinations. Then it may produce delusions. Then it may produce, yes, frank psychosis, full psychosis. Do you think all this is good news for the patient? So what really I'm trying to teach you? I'm trying to teach you that when you, with the levodopa, you add the carbidopa and entacapone, please reduce the dose of levodopa. So whole this strategy will end up that you significantly reduce the dose of levodopa, but still amount of levodopa reaching to central nervous system is increased with reduced peripheral side effect. Is that clear? Right, because if there is excessive dopaminergic activity in central nervous system, right, it will specially translate into dyskinesias due to excessive dopaminergic activity in basal ganglia and striatum, and it will translate into excessive dopaminergic activity in limbic system, will translate into psychiatric complications like anxiety, confusion, hallucinations, delusion, psychosis, and even still others. Am I clear? No problem into this? Now, this should be a basic rule as a doctor in your mind. Whenever dopaminergic activity in the CNS is excessive, the basal ganglia side effect and the limbic side effect. Why I'm again and again telling you, there's a reason. Because levodopa is sometimes combined with direct dopaminergic agonist. And again, then levodopa dose should be reduced. Are you understanding? That levodopa, sometimes we give it along with bromocriptine and other drugs which can directly stimulate the dopamine receptors. Those are right. But then levodopa dose need to be reduced so that total dopaminergic activity should not be so much in excess that produce basal ganglia overstimulation with dopaminergic system or mesolimbic overstimulation with dopaminergic system. Am I clear? No problem up to this? Right? Now, okay, if pharmaceutical companies, they are really clever, and it is good for patient also, that they are producing combined tablets. Number one, a combination of levodopa plus with that carbidopa. Carbidopa. What is this combination called? Who will tell me? What is this combination called? This combination is called Sinemat. Sinemat. Actually, in present modern management of Parkinsonism, there is no concept giving levodopa without carbidopa. That is why they are coming in combo. Presently, there is no concept of giving levodopa without carbidopa. That is why the combo which is marketed, the combination of levodopa with carbidopa is called Sinemat. Then, of course, they have three things combined together. Levodopa, yes, plus carbidopa plus, what was the third friend? Entacapone. Carbidopa will catch the dopa decarboxylase and entacapone will grab the COMT, and then you will end up with a wonderful combo for the patient. What is the name of this combo? This combo is now available, widely and very successfully being used. Stalevo. Stalevo. Is that right? STA, sta, levo. Right? Am I clear? So this double combo or triple combo is now available, right? And of course, we are careful, we keep the levodopa dose down, right, in these combos, so that does not produce CNS side effects. Any question up to this? Now, when you start the levodopa therapy, in 1/3 of the patient there is wonderful response, right? All the symptoms are eliminated at least for few initial years. Remember, levodopa work only for few years, 3 to 5 years. After that, effects of the levodopa last, but side effects become more. It's a very sad news that you are using a drug as you use the drug more and more over the years, rather than drug gets friendly with you, drug gets nasty to you. That effects of the drug reduces and side effects of the drug increases. I will explain how. But for a while you just trust me that on average when we start in 100 patient levodopa therapy, in 1/3 of the patient there's wonderful response. In 1/3 of the patient there's mild to moderate benefit. And remaining 1/3 of the patient, there are only side effects. No significant advantage of taking the levodopa. You may be thinking why it is so. Why some patients respond better and why other patients respond poorly and some don't respond at all. You know the answer, or should I explain? Anyone who wants to explain it? Amal? Would you like to tell why different people have different degree of responsiveness to levodopa? Let's suppose that we are giving the levodopa along with the carbidopa. Then, look, we have to address a very fundamental issue of pathology of the disease. That when patients really come to you with the well-defined Parkinson's situation and you are going to treat the patient, do you think how much percent of the nigrostriatal neurons are left there? Of course, if I have, suppose, whatever number of nigrostriatal pathways are right now in my central nervous system, if, for example, 10% of them are destroyed, I don't get the clinical features of Parkinsonism because remaining 90% will compensate for the loss of 10%. There should be significant loss of neurons before the Parkinson's clinical symptomatology becomes evident. What do you think? About 80% are destroyed. Before someone is really diagnosed with Parkinsonism in clinical practice, 70 to 80% of the nigrostriatal neurons are already destroyed in Parkinson's disease. Am I really clear to you people? Now, once you start the levodopa therapy, actually, as I told you previously, that this therapy does not address with the initial issue of progressive loss of neurons. So in spite of starting the levodopa therapy over the years, there's further loss of the neurons. Is that right? Now listen carefully. Let me make a diagram here. I don't know why I love teaching so much. I think it releases endorphins in me. One day I think someone will ban lectures on me saying that it has something to do with addiction. Okay, listen. Now what is happening that, suppose these are dopaminergic neurons in substantia nigra, there are a lot of them initially, right? And all of them, they are going there and producing dopaminergic nerve endings. This is substantia nigra, and what are these? These are nigrostriatal pathway, and these are their nerve endings. Is that clear? Really? What was really happening? That before the disease start, let's suppose 80% are already destroyed. I'm just showing the remaining 20% of nigrostriatal fibers in this diagram. When you are giving levodopa, actually these are the nerve terminals which are taking that levodopa, converting into dopamine and storing that and releasing that. Is that right? For the action. Am I clear? No problem? Now, let's suppose you come across a patient who has started recently displaying the features of Parkinson's disease and you start giving the levodopa, there is a very good response. Why there is good response? That these nerve terminals are there in enough amount. There is enough nerve terminals there to take up the levodopa and convert into dopamine and store it in enough amount so that they keep on releasing and striatal system keep on working in a normal way, and result is what? That there's a very good, you can say, symptomatic treatment. We say there's a very good response to the drug. While you keep on giving the drug, progressively these nerve terminals are increasing or decreasing? They are decreasing as more and more neurons are destroyed. So as this progressive loss, it means the nerve terminals which were supposed to take this precursor and convert into the dopamine and then store it and then release, they are becoming more or less? Less. So in spite of you keep the levodopa dose same, the capability of remaining terminals to maintain the dopaminergic activity in striatum is reduced. So what happens? Drug become more efficient or less efficient? Less efficient. Because this is a precursor drug. And efficiency of this drug primarily depends on the remaining dopaminergic nerve endings which are capable of converting into dopamine and storing it and releasing it. As disease advances over the years, this is a very important concept because you are supposed to discuss it with the patient before starting the treatment of levodopa, that I'm starting a drug, right, but its effects are not lasting. They will only help you for a few years. And progressively, its actions will be lost. Why? Because underlying loss of neurons is progressive. Nerve terminals available to take up the levodopa and convert into dopamine and store it appropriately and then being released properly, those nerve terminals progressively become less. So what is the result? That drug is not losing its efficiency. Am I clear? That is why in 1/3 of the patient, they come with so advanced loss of the nigrostriatal nerve terminals that even from the very beginning, levodopa may not be efficient. Now you understand that in some patients there will be good response, some patients there will be moderate response, and in some unfortunate patients there may not be any response. Yes, please. What's your question?
How do you measure the quantity of neurons that in the patient? Let's say you get a patient now and then you want to measure how many neurons are there working.
We don't measure it. Clinical response tells us. Is that right? Of course, experimentally we can measure it. We have specially labeled antibodies and PET studies and many ways to determine how much dopaminergic activity is present in striatum, but it is not cost effective to measure in every patient. Simply you give the levodopa and see what happens. If patient dramatically improves, it means that there is still enough nerve terminals are there to handle this levodopa, that they are doing their own synthesis of dopamine and they can do extra synthesis of dopamine and store the dopamine and compensate for the lost neurons. But of course, when loss progresses, eventually number of nerve terminals become so less that with their all full action, they cannot compensate for the lost dopaminergic activity. Is that right? That is the basic reason why drugs, you can say, loses action over 3 to 5 years. And there's another bad news and sad news. Some people believe that dopamine in the central nervous system is broken down into some metabolites which can further lead to the loss of these neurons. It's worth listening again. They say that when dopamine is catabolized in central nervous system, its breakdown products, some of them are neurotoxic for substantia nigra and lead to further loss of the neuron. That is why now they think it will be wise that you start with the drug, initially in the disease, you start with the drug which can directly stimulate the dopamine receptors. That is why the dopamine receptor stimulators, especially non-ergot ones, which are, which one? Pramipexole and ropinirole. They are coming as more effective drugs, as first-line drugs. They may not be as effective, but at least they may be taken from the very beginning. Because if you are using those drugs, and if you want to use levodopa with them, then dose of the levodopa required will be further reduced. Is that right? So this was something about response to the drug, and decreased responsiveness is due to two reasons. One reason I have explained well, that decreased responsiveness over the years is due to loss of neurons. Second reason is that fluctuating response or decreasing response over the time is due to changes in postsynaptic membrane. Because striatal GABAergic neurons, which are having the D2 receptors and D1 receptors, let's see here. These were the neurons, right? These neurons were having dopaminergic receptors. Am I right? Actually, due to sudden on-off situation, due to levodopa when we are giving, naturally when peak level of levodopa comes, dopamine is excessively released. When trough level of levodopa come into blood, of course, in the blood from the GIT, when you take the tablet, within 1 hour, there are peak levels of levodopa in the blood. And before the next tablet, there are trough levels, the lower levels of levodopa. This fluctuating supply of levodopa to these terminals lead to fluctuating and not a physiological, rather pathological fluctuations in dopamine activity on postsynaptic membranes. And these alterations also lead to the receptors alteration. Dopamine receptors are altered over the years, as well as dopamine receptors are intracellularly coupled with G proteins. Even G proteins and their downstimulatory pathway may be altered also. We say there are certain adaptive changes to the postsynaptic membrane, and that may become resistant to the action of dopamine. Is that right? That also lead to the loss of responsiveness to the levodopa over the years, right? Let's have a break now.